talk about postpartum management of hypertension and future risk. Next slide. We've already talked a lot about postpartum hypertension, but I would like to make sure that people understand that the best blood pressures in the postpartum period are going to be in the hospital. They're taken, the blood pressures are taken when the patient's often in bed and they haven't been walking around or up and down taking care of the baby. So we need to be aggressive in the postpartum period, and people who go home on antihypertensives need to be followed up in 1 week. Next paragraph, or next slide. So the big issue with antihypertensives are whether or not the patient is breastfeeding. Calcium channel blockers, if you read about African Americans, calcium channel blockers is the #1 drug that's recommended for them. And beta blockers and methyl-dopa are not on that list. Hydrochlorothiazide and furosemide are both acceptable postpartum blood pressure medicines, but you cannot use ACE inhibitors or ARBs in a breastfeeding mother. Now, I can tell you your lactation consultants will say do not use hydrochlorothiazide or furosemide, but I looked both of them up last night and both of them are compatible with breastfeeding. And all the ones above are compatible with breastfeeding. Next paragraph. So when a patient comes back and they have hypertension still in the postpartum period, we can start talking with them about lifestyle modifications, because anytime you have hypertension, the very first thing that the doctor talks with you is about lifestyle modifications. We particularly need to talk about weight loss. You know, their diet, put low sodium, more potassium. There's the DASH diet, there's the Mediterranean diet, if they want to go and choose some of these diets that actually have been shown to decrease blood pressure. One of the most important things we can do is physical activity. Just walking 30 minutes a day, and it doesn't have to be 30 minutes all at once. It reduces strokes, it reduces heart attacks, it overall improves health. And if you told somebody that you had a pill that would reduce their risk of stroke by 40%, their heart attack, renal disease, mental health, sexual activity, I mean, a lot of people would pay a lot of money for that pill. Well, physical activity is basically free, okay? And so even just parking at the back of the Walmart parking lot and walking all the way to the store will give you probably 7-8 minutes of physical activity. And then the last thing is alcohol raises blood pressure, and women who have hypertension, they should use alcohol in moderation. Next slide. So we have known from the Chicago days that preeclampsia, the people with lots of proteinuria, 5% of those are have underlying renal disease that never goes away. That's why it's so important to dip their urine at 6 weeks to 8 weeks postpartum to see if they have persistent proteinuria. Because if they still have 3+, 4+ proteinuria, consider getting a PC ratio and referring those patients to renal. Because again, 5% of patients with renal disease with proteinuria can have persistent renal disease. And we've known that some patients with preeclampsia actually have chronic hypertension. And so you need, if a patient is 12 weeks out and still has hypertension, she needs to be referred to her primary care doctor. And then there was a question of whether or not people who have preeclampsia, if this causes cardiovascular disease in the future. Next slide. So around 2000, we started getting publications. This is one that came out in 2005. It was the CHAMP study. And they talked about the maternal placental syndrome. So they labeled the maternal placenta syndrome as preeclampsia, gestational hypertension, abruption, or placental infarcts, okay? And so if a patient, the top on the y-axis is the chance of being free of the cardiovascular disease, and x-axis is the number of years from the index delivery. So the blue line at the top is unaffected pregnancies. So you can see those women at 15 years out have a very small risk of having any cardiovascular disease. Then if you look at people who have maternal placental syndrome, that's in the yellow, they have a higher risk of having a cardiovascular event. And then the green line is the maternal placental syndrome and poor fetal growth. And the people who have the worst outcomes are people who have maternal placental syndrome and fetal death. So there has been other studies looking at early onset severe preeclampsia, recurrent preeclampsia, to see if any of these can also affect cardiovascular health. And the answer is yes. The more additive things you have, the more likely you are to have a cardiovascular event. Next slide. This is one of my very favorite slides, and I think every cardiologist in America should have it. So on the top line is maternal placental syndrome, okay? So you can see the dot and the confidence interval. Now, if you look straight down, there are very few lines that are to the right of that has a higher hazardous ratio. The one underneath it is patients with chronic hypertension. Now, the next one underneath it, if you have chronic hypertension and then a maternal placental syndrome, then your risk is much, much higher than if you just have chronic hypertension alone. The next one, you can see maternal placental syndrome is approximately the same as diabetes. And if you combine the two, it makes it much higher. Again, maternal placental syndrome is higher than obesity. The next line, you can see that. But if you combine obesity and maternal placenta syndrome, then it continues to get worse. And so that is the way it goes all the way down the chart. Go down to the second to the last line. Look at maternal placental syndrome, the first line. compared to the tobacco use, which is the second from the bottom. And you can see maternal placental syndrome and tobacco use their hazard ratios are very similar. Their confidence interval is just a little bit different. So in 2011, the American Academy of Cardiologists actually decided to put severe preeclampsia in the definition of at-risk patients for cardiovascular disease. But anytime you see a patient and she's seen a cardiologist, you ask, did they ask you about your obstetrical history, like your deliveries and where you had any complications? And a lot of people still don't do this. Next slide. So when we're seeing these people with severe preeclampsia at 25 weeks, we really do not know what to say to them. But we can do the what we would suggest to anybody with cardiovascular risk. And that is they should have a yearly exam. They should monitor their blood pressure. They should check their lipids. They should do diabetes screening, and they should have a normal BMI and continue to exercise. And we hope that a combination of those things will actually decrease their risk of cardiovascular disease in the future. And that's it. Any questions regarding that?